Hello and welcome to today's webinar, Using AI to Solve the Ghost Network Problem. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Dr. Neil Vitala, co-founder of HiLabs, and Sanjay Acharya, HiLabs Senior Vice President of Strategy and Growth. At this time, I would like to turn the floor over to the speakers.
Thanks, everyone. We appreciate the opportunity to present on using artificial intelligence to solve the ghost network problems on behalf of the HiLabs team. Just a little bit about ourselves. I co-founded HiLabs and serve as the Chief Medical Officer. I'm also Assistant Professor at the University of Colorado School of Medicine, where I run a lab focused on artificial intelligence and its application to healthcare data. I'm also a practicing cardiologist and medical director of structural heart disease and intervention at the VA Eastern Colorado Healthcare System, and I was previously at Harvard Medical School and interventional cardiologist at Mass General Hospital in Boston. I'll hand it over to Sanjay.
Thanks, Neil. Thanks, everyone, for joining. Hi, my name is Sanjay Acharya. I'm Senior Vice President of Strategy and Growth at HiLabs. My background, I've been in kind of healthcare health plans for the past decade, primarily in the consulting space. So I've been at places like the Advisory Board, the Boston Consulting Group, did a stint at CVS Health in their internal ops consulting group in the specialty pharma world, and then worked at a boutique consulting firm in DC that did quite a bit of work for CAQH, and there I learned a lot about provider data. I think some of my CAQH friends may be on this webinar, so thank you for joining. Got a lot of good insight into provider data there, and have been at HiLabs for the past 2 years, where I work closely on all of our products, but with a specific eye to the provider data area. So yeah, that's my story.
Thanks, Sanjay. So to review our agenda today, we're going to talk briefly about HiLabs and then dive right into the ghost network problem. And then we'll do even a deeper dive into the origins of ghost networks and why they persist. And then finally, we'll talk about how technology can combat ghost networks. To start off about HiLabs, we're on a mission to transform healthcare by unlocking the hidden potential in dirty data. And so we serve 4 out of the 10 largest health plans in the US, as well as a number of specialized Medicaid plans and a number of regional Blue plans as well across the country. As you can see, the numbers here are pretty large. We deal with a lot of data. We've trained our models on a substantial different set of metrics as well as data points. We've worked with provider data, which we can talk about today, as well as claims data, in addition to clinical data, so EHR data that comes into plans, and finally population health data as well. So we've covered a number of different types of data that health plans see, and really focus on using our technology and AI models to improve the quality of that data to improve healthcare operations for health plans more broadly. So talking about the ghost network problem. So as you all probably know, health plan provider directories are full of inaccuracies. And so this is a paper here, I think, on the consistency of physician data across health insurer directories that we published, HiLabs in collaboration with the University of Colorado and JAMA a few months back. You may have seen it. We essentially examined health plan provider directory entries for over 40% of all US physicians across 5 large national health insurers. We found inconsistencies in these entries for 81% of physicians examined. About 72% had inconsistent addresses across the directories in which they're found, and 32% had inconsistent specialty information across the directories in which they are found. So this is pretty substantial in terms of the magnitude of the problem here. And this is, again, just the data was captured in the last year or so. It's a pretty recent data. So these provider directory inaccuracies can actually lead to the creation of ghost networks. And so ghost locations are provider entries listed in health plan directories, but they're locations where providers are actually unreachable, not accepting new patients, or not in network. And so if you sort of look at the magnitude of ghost entries, one can see that they actually represent a substantial portion of what's listed in a health plan provider directory, if you look more broadly. And if you actually go and remove the ghost entries, a lot of times what patients are left with, or members are left with, is a much narrower picture of options that they actually have for actually reaching and seeking care. And so this is a big problem in terms of its magnitude and its effect on patient care. So thinking about, the consequences this can have for patients seeking care. So an example here, let's say a patient searches for a mental health care provider for a particular issue. That patient then sees, a number of mental health providers available in the health plan provider directory as the place to start, but none of these are actually accepting new patients. And this can lead to substantial issues in terms of accessing care in a specialty where it's particularly challenging. And then ultimately the member can't receive the care they need. And this leads to downstream consequences, not only for the member, but also sort of downstream healthcare costs and utilization. And if you think about this at scale, this can be a substantial portion of the things that people encounter as they're searching for providers and health plan directories. And this can actually lead to substantial costs for the healthcare system overall, as well as health plans, in addition to just being bad for patients seeking access to care. So overall, a big problem for members trying to access their care. In addition, ghost networks may misrepresent networks to patients, as well as network adequacy to health plans. And so, every year when people pick their health plans, as you're choosing, you want to make sure that a particular provider you seek is actually in the health plan directory, they're covered in network. Ghost network locations can actually misinform consumers when choosing a health plan, and that's a big deal. Now, beyond that, it can actually misrepresent network adequacy in the sense that health plans must meet regulatory requirements for this. And oftentimes, these ghost network locations don't necessarily represent how narrow a network is. And so these are sort of regulatory issues as well as issues with regards to just consumers choosing plans and sort of member enrollment. So this has been recognized, and especially recently, there's been a call for congressional action. This is an article published, I think, last month in The Hill, where Congress is really urged to tackle ghost networks amid this mental health crisis. So here on the right, you can see just some quotes from the article. There's actually bipartisan support for this, which is pretty rare, to really, generate legislation to address the ghost network issue, in particular with regards to mental health care. And the Senate Finance Committee, actually, that's overseeing this, conducted an audit of Medicare Advantage plans and found that over 80% of the listed in-network mental health providers they attempted to contact ghost entries. So there's really a renewed call for action here. And that really prompts health plans to be more proactive, get ahead of this, especially given the magnitude of the problem. So I'll pause there and see if there's any questions, because that sort of concludes the first section of content here. And so I see one question. How prevalent are ghost networks? That's an excellent question. We don't really know, right? So there's this, secret shopper study that the Senate Finance Committee did that 80% of mental healthcare providers that they contacted were ghost entries. And our JAMA study also was kind of 80% of at least physicians had inaccuracies or some sort of inconsistencies across the directories in which they're found. So I suspect it's a pretty high number, we just don't know. And it may vary by specialty, it may vary by region. And that's something we're actually looking into with the data we've collected as a follow-on paper to the JAMA paper. But there's certainly, a large knowledge gap there. But it's definitely a big problem. One thing we did note as we're looking in that data, there's actually not much variation by insurer, meaning that almost all insurers have, a large problem here. It's not necessarily confined to the operational process of one insurer. It's essentially, incorrect data coming in from providers that actually leads to this problem. The providers send similar data to all insurers. So it's more of a universal industry-wide problem that we're hoping to tackle. any other questions here. Number. So, yeah, there's a question in our JAMA study. How do we figure out who's correct when we compared across health plans? We actually didn't know, but if there's two things that are inconsistent, one of these is incorrect. So we didn't have a gold standard. And it could be that the number is actually higher and that all the information across all 5 health plans is incorrect. If the physician moved and hasn't updated their information. So I guess what we reported is actually an upper bound of the correctness, so a lower bound of the inaccuracies. The problem may actually be worse than what we published, just because we didn't have a gold standard, but that's an excellent question. Interesting other questions here.
It looks like there's one about, have we found that the majority of ghost networks are intentional or unintentional by insurers? So our insurer is not, correcting their data due to lack of staffing or resources. So I think I can help speak to that. So I think in general the challenge is more global. So I don't think providers intend to send data that's inaccurate, and I think also insurers don't intend to publish data that's inaccurate, right? In that sense, nobody really wins. I think it's more the fact that there isn't a lot of standards or requirements around this data, and it's sort of a function of how the system operates, right, to some extent. So I don't think there's any intentionality on either end. I think in some cases, providers make unintentional errors on the data that they send, and then health plans, publish that data. And I think the reverse also occurs, where health plans are unintentionally publishing some data that isn't accurate, or some things might get lost in translation when they're receiving information from providers. But I think overall, right, it's an industry-wide challenge, and it's recognized on both payer provider sides and other entities that it's a general challenge, and we need to try to do better there.
Okay, there's a lot of questions. We'll take one more in this section. Just why do providers provide incorrect data? And they don't mean to, and it's hard, right? It's actually a very hard problem. It's quantified to cost, almost $3 billion for the providers in the United States just to provide this data to insurers. And this is on top of all the patient care they do, right? Like, my job is taking care of patients first. Most of my practice is organized towards that. And sort of this administrative burden that falls on sending, this information to different insurance health plans at different standards, at different frequencies, is challenging. And it's in my interest to make sure that my physician information is correct, which is really hard. And there's a lot of other things that take precedence, including sort of patient care. So and Sanjay can talk a little more about that, but I think we'll probably pause here and we can maybe address some of these questions later to make sure we get through all the content.
Yeah, thanks, Neil. I'll go ahead and take the ball here. So we talked quite a bit about the kind of ghost network problems. So we're going to go through and describe with a couple of examples, where do these ghost networks come from, right? And this may speak to some of the questions about intentional, unintentional information exchange, right? And so here we'll go through a couple, and these are, by no means exhaustive, but these are some of the examples, we've seen out there in our work that have kind of led to some of these ghost network locations, right? So in this first flow, you can imagine something like you have Dr. Smith, they're moving locations from 123 Main Street to something like 456 New Avenue, and maybe they're practicing within the same group, right? And so the group, when they're sending this data across to different health plans, they, they're not sure that Dr. Smith has moved. They're not quite akin to that change, or for whatever reason, they don't kind of deactivate location 123 Main Street and activate 456 New Avenue. They send both as active, right? And so when that happens, the plan will kind of consume that information, and they will reflect that, Dr. Smith is practicing both at 123 Main Street and 456 New Avenue, and this 123 Main Street location will effectively be a ghost location since Dr. Smith doesn't indeed practice there. Similarly, in the second flow, here you might have a larger scenario where Dr. Smith is actually just joining, completely moving from one group to another. So in this case, Dr. Smith is moving from, Doctors USA to Doctors Plus, right? And they're now no longer going to practice in any of the Doctors USA locations. In this case, maybe Doctors USA doesn't inform plans that Dr. Smith is no longer there, or there may be some timing as Dr. Smith exits. the group. In this case, right, you're going to end up with a similar scenario, but at a larger scale. Doctors Plus is going to inform all plans, right? They're excited. Dr. Smith has moved to them. They're going to inform all plans that, Dr. Smith now works for us and, at all these different locations. But those Dr. USA locations that list Dr. Smith will kind of live on within the health plan directory until it's changed, right? So you'll end up with all of those Doctors USA locations as Ghost Network locations. And in the last flow, this is one where you see this more as providers consolidate. This is where a scenario where Doctors USA, they may choose to purchase Doctors Plus, right? So one physician group is merging or acquiring another one, and in this case, there may be some overlap in locations. So Doctors Plus decides to shut down something like half of the Doctors USA locations due to overlap. But then when they're reporting that out, when they're kind of sending information to health plans, they may not update those half of the locations that are closed, right? There may be some lingering impacts of closing those locations. Again, there might be some sort of timing challenge, but they're not going to update that to the plan. And so now those locations of Doctors USA that were supposed to be closed and are no longer active will continue to be there in the plan directory, and Dr. Smith and other physicians will be shown to be practicing there. And so when we went through this, these are what we've seen. Many are often from the provider perspective, but they're by no means exhaustive. And on the plan side, there are also challenges in terms of processing this data, right? Plan providers may send certain flags within their data that plans didn't interpret correctly or couldn't process accurately. And we'll take a look at some of those examples in our when we get into the solutioning component. But you can see there's kind of a wide variety of reasons this can occur. And most of the time, it's due to some sort of change, right? At the provider end, the doctor's changing locations, you have some consolidation, you have some location changes, whatever it might be. And those changes don't exactly get reported and translated back into the health plan directory system. And you can kind of tell, right? So in general, right, especially when providers are moving around, the groups, they don't have a ton of incentive to report when a provider leaves, but they have a good amount of incentive to report when a provider joins, right? So if provider leaves my practice, they're no longer with me, and so I don't have a ton of incentive to report that out. And these are really costly, right, on the provider side, right? So if you think about it, right, providers' main charge is to provide good patient care. This is a kind of non-patient facing administrative burden to them that already adds a lot of cost, right? Estimates are in the $3 billion plus annual range just to, update and manage all of these provider data updates headed to health plans. And so asking for additional diligence or effort here is a big challenge for providers. And then on the plan side, health plans generally may have some fear, right? If they discover these locations, putting them back may actually decrease their overall network adequacy, or at least that's the fear. We've actually found this to be false. And when you use the technology that's out there to kind of remove and prune these ghost network locations, you can also source new locations that are accurate that can be added to the network that can help fill in those network adequacy gaps. And we'll look at an example of that a bit later in the presentation. So we'll pause there in terms of the origin component for another couple of questions that may come up. So we'll open it up to the audience. We want to make sure we try to keep this interactive. So it looks like we've got a couple of questions streaming in. So one is about, do providers have any mandates about reporting these physician addresses or these changes? So to our knowledge, there isn't anything legislative out there or even, kind of a softer requirement. There are some regulations and requirements on the health plan side to make phone calls, do some just to ensure that their directories are accurate. And I think I know from my experience, health plans have been working to find ways to also involve providers in ensuring that this data is accurate, but I think those efforts are pretty nascent. We have a couple other questions below. I'm just kind of scrolling through here. There's one about is all the ghost network challenge, is that due to data provided from providers and that's not accurate or up to date? Is that the only cause? And so I think the answer to that question is no, right? I think those are the examples we've shared or what we've seen is common, but there are also challenges on the health plan side in terms of processing this data. And we'll see an example of that later as providers share that data in rosters. A lot of different things can happen that make it challenging for plans to actually process that data. So we'll share a couple of those examples. And then it looks like there is a question about do plans gain by, publishing ghost networks, right? Because it makes their networks appear larger than they should. And I think the answer is potentially, but I don't think this is an intentional component by insurers, right? Because they may have, show a larger network, but at the same time, they're incurring a lot of cost and regulatory scrutiny. If members are complaining about an experience, right? If I, thought a provider was in my network and they're not, as a member, I'm going to complain, right? I'll probably go to a regulator or I'll change plans. It's not really keeping with a solid business practice. So, they may gain some benefit from that in the short term, but I think longer term, it's a thing that plans are worried about, and they're putting a lot of effort into this area to try to improve this data quality of their directories, and we've seen that across the industry.
There's one more question, Sanjay. I think that
Yeah.
there's a lot of, I think one that's important that we may or may not get to, but is there any source of truth here for these locations? And the answer is no, right? Which is why it's such a hard problem. And so there have been attempts, but none of these have actually been updated because it's such a dynamic problem, right? Doctors move from one place to another, and it's pretty high frequency at which this happens, and other providers as well, beyond doctors. So there's no source of truth, but that's why, use of technology like AI can actually get you a pretty good answer, like pretty close to the, what the truth is. And so, we'll talk about that in a little bit, but advanced technology is actually perfectly suited for these types of problems where it's really complex data, where you kind of get an overall gestalt or sentiment of where someone is. And that actually works out pretty well, especially using some of the newer technologies like large language models and things like that power ChatGPT. Like all that kind of advanced AI stuff, which we'll talk about in a minute, is actually perfectly suited for solving this sort of problem where there is no source of truth that's easily ascertainable.
Yeah, thanks, Neil. And yeah, we will. That is probably a really good segue into our next section. So let me go ahead and move into our next section where we'll talk a little bit more about solutioning here. So it's a bit of a complex diagram, right? But I'll kind of walk through it. And as Neil mentioned, when HiLabs has been solutioning for this, we've developed a capability or a product that actually looks at both the data ingestion side, so taking data in through the provider roster channel to kind of automate and quality check that data upon entry using AI solutions that are powered by a lot of these large language models, similar to what you've seen in ChatGPT. And then we also look to cleanse and remove ghost network locations out of the health plan database after that data is loaded, right? So you're constantly checking and making sure that data that a plan is publishing is accurate in terms of directory locations. And so we'll walk through the first component first, which is the roster piece. And this may help explain why, even on the health plan side, it is challenging to kind of process some of this data. So let me walk through that. So in our experience, right, these roster files, and for those of you, I would assume many in the audience are familiar, but if not, basically when large provider groups or hospital entities or even smaller provider groups, when they're trying to send their data updates to health plans and say things like, I have this many doctors who work with me and they all work at, these different locations and these are their specialties and this is when they work. they usually send them in these files known as rosters, and you can think of them as just kind of like basically large Excel files, more or less. And we found that this seems simple, but this is actually an incredibly complex problem. So this is an example we like to share where for a single plan for their set of rosters, we found that there are 25 different ways to represent the first address or address line 1 by a provider. So you can see a lot of these different examples on the right-hand side. So some providers send in a roster file that calls this service location 1. Some send it as office address. Some send it as service address. Some send it as address street, and so forth. So you have tons of variation, and that's just on that specific data element in these rosters, right? We've seen over 90 different ways that specialty is termed, right? So, and none of this is, this isn't like claims data. There isn't a standard here, and so it's not surprising that you get so much variation. But on the health plan side, right, you can, using any sort of traditional method, you'd have to write, thousands upon thousands of rules to manage all this variation. Whereas for an AI solution, this is actually kind of the perfect challenge, right? So in this case, you're really looking to handle slight variation that's different, but is kind of intuitive, right? As a human, you could probably read this and tell which of these probably means address line 1. And our system does that exactly. We kind of read this data as a human would using this kind of large language technology, and we're able to process it. And we'll walk through a couple of examples next to illustrate that point. So the first example, right, is this is where you may get an incoming roster one time from a provider where the first name is in the first column and the last name is in the third column, and the next time last name will be in the first column and first name will be in the second column. And that's for a typical solution that's a pretty large challenge. But for our solution, the column order makes no difference, right, to our engine. We'll map that correctly. And if you think about that at scale, especially with something like an address data element, you can see why even if a provider might be sending accurate information, the plan may be having a lot of challenge in terms of processing that data and reflecting it correctly in their system. Another example we've seen quite a bit of is where these column names may actually be named the same thing. So if you look at the top line here, you'll see issue date and expiration date listed twice. Again, as a person, you might say probably the issue and expiration that's closest to the license number is a license component, and the one that's closest to the DA number is probably related to DEA. Again, as a person, easy to read and intuit, but for a traditional solution, very difficult. But for our AI system, right, we can kind of read that context just like a person would, and we would be able to map those appropriately. And then the last example is where you might have the same name for a column, but it's different content. And so in this case, our system, just like a person would, will read from the content, right? So in this case, you'll see two columns titled with LN. The first one in blue, it's next to first name. You can see a lot of alpha characters like Doe, Smith, Beckham, etc. So our system would interpret that as like that is likely a last name of a person, and we'll tag it as such. The other one in green, right, we would look at that and the system would say, well, we've got some letters and numbers, it's this many digits. That looks a lot like a state license number, right? And we'll map it that way. So our system is kind of capable of taking in all this data, standardizing it, and then outputting it to a format that a health plan can consume. So hopefully all the kind of potential quality errors with addresses that can create ghost networks, like those will be eliminated from the ingestion perspective. But that's only part of the problem, right? So the second part is, maybe I can load this data into my database, but now I have to check whether it's accurate or not, right? And this is where, again, we're using a lot of this latest technology in terms of large language models, et cetera, to bring together thousands of different sources that are publicly available and that we can leverage from within the health plan to kind of score and provide recommendations on these different provider data elements, especially the address piece that creates these ghost networks. So we'll do things like, scan a provider website and look through, where does, group A or this hospital, where do they say Dr. Smith practices at, right? And that's really difficult because the variation in websites is massive. You need a lot of kind of advanced NLP and LLM capabilities to extract that data, but we're able to do that. We can comb through any sort of third-party web sources that are aggregator sites like a WebMD or a ZocDoc, and anything else that's kind of publicly available provider directories. So we'll bring all that data together. And then we can further increase that accuracy by leveraging a health plan's data. So we can read through, things like provider contracts, again, using NLP, leverage any existing provider data in a plan's database, looking at claims data, things like, did a provider send a claim from a particular location? If they did, right, it's likely they practice there. And then we can also leverage data from any other source that a health plan has access to. So anything from a player like Quest, as I mentioned, CAQH does a lot with attestation of provider data, and LexisNexis is a data provider as well. We can consume that data and use it to enhance our overall scoring and recommendations. We don't bring those sources to the table because they have to be paid for by the plan, but if they have them, we can consume them and use them to enhance our accuracy, and that will produce a recommendation where you can kind of ferret out what those ghost network locations are and remove them at scale from your directory or from the plan directory. And I'll walk through this with an example, right? And this is a kind of fictitious example. I'll say we've changed the physician name to Dr. Jane Smith, but this was a real example somewhere in the state of Michigan, right? And our system will take in all these different directory locations that a plan has. And so we can see in this case, you have Dr. Jane Smith, she practices internal medicine. One of the directory locations is that a plan has listed is this 43650 in Garfield in Clinton Township in Michigan, right? So we would walk through that process I mentioned before. We'll take in all that data and try to come up with a score, right? In this case, for that particular location, our system would score this at 0%. It's likely that Dr. Jane Smith does not practice at this location. When we looked at this in more detail, you can see on Google Maps, this place was previously a physician office, and it recently shut down and is available for rent. So it's a good bet that Jane Smith doesn't practice there. And so this would be one of those, kind of ghost locations that's out there in a provider, that's out there in a plan directory that should be removed. Similarly, we can tell plans where we think that you have an accurate location. It's not a ghost network location, so you don't have to do anything with it. That's 550 Munson Avenue here, where our score is very high, and a plan can then not concern itself about whether or not that's accurate or is inflating network adequacy. And then we also have the blue locations, and this is where let's say you remove those red locations, you may have those ghost network locations. You might start to develop a hole in network adequacy. The same technology that goes out there to say whether or not these locations are accurate can also be used to source new locations that are accurate and for whatever reason aren't listed in the directory. So in this case, we found one at 1105 6th Street. This is one where this is not in the health plans directory, but it looks like a location Dr. Smith likely practices at. And so the plan can consider, adding that to their network, so that, they have, they're not losing anything in terms of network adequacy, and they're providing members with, more accurate data. Maybe somebody lives a lot closer to 1105 6th Street than they do to another location, and now they can go there if that's in the directory. And we can take a look at, how this looks in practice, right? And again, this is illustrative, right? So we could take a plan directory, perhaps in the state of California, and maybe their network adequacy is at 88% at baseline, right? And this is the kind of perceived network adequacy. This is before you're doing any sort of quality updates or removing any sort of ghost network locations, right? And just as I saw on the prior location or prior slide, let's say you find a bunch of those red locations and you need to remove them because they're ghost network locations. So by definition, your network adequacy is going to fall because you've removed a bunch of provider directory locations from your directory, which you should do because they're likely ghost or inaccurate. But then lastly, we'll look to add in those blue locations, right? The ones that we've sourced using the same technology where these providers do practice, but for whatever reason are not in the plan directory. And in our experience, we found that we can actually find more than enough locations that are accurate to kind of fill in that network adequacy gap created by removing those ghost network locations so that the plan ends up in the same place, if not better, after they go through this type of process. So that's how we kind of help remove the ghost networks or ghost network locations, but also add in good locations so that network adequacy is still high, and members get to see the most locations possible where they can seek care. And the best thing about this at the end is that this is going to be accurate data, right? You shouldn't have any of the challenges where members can't access the care they need or find the physicians they need to get to their care. So I'll pause there again. I think that ends the formal content. So we'll open it again for any other questions the audience may have. And I think there are a couple that have come in throughout, so I'm just trying to scroll to the most recent ones. So there's one about the accepting new patients flag. One of the challenges found frequently is with this data element, especially for Medicare. Who actually holds responsibility for this particular element? Is this doctors' plans, or is there another entity that does this? And so I think for this one, right, the A&P flag tends to be a challenging one because panel status for providers changes often. I think typically it starts with the providers sharing this data on whether their panel is open or not. And then plans can augment that typically based on uh, claims data, or if they're kind of making different arrangements in terms of the panel that a provider can take. So I think it starts with the provider, but it can be shared with the plan as well. In our experience, the techniques we've used, especially when combined with claims data, can help provide better insight into that A&P flag, whether it should be true that you're accepting new patients or not. There are a couple of line of business specific uh, adjustments we need to make, just depending on, sometimes plans will or providers will take patients for certain plans or certain insurances and not others. So we need to manage that a bit as well. There's another question about confidence level, right? So how should a health plan react if their scoring is not 100% positive on this scale, right? Um, so we in our experience, we have some thresholds that we found to be um, pretty good out of the box. And it's usually in that 90%. When we're 90% sure something is wrong or something is right, you can generally take it to the bank, or there's very low risk in terms of taking an action against that. Um, we've changed that to be higher. We've changed that to be lower. It generally depends on two things: the risk tolerance the plan has for making these updates, one, and then two, the operations overhead that the health plan operations team can take on. So I guess the answer is generally it depends, but we have some clear out of the box defaults, and most of the time that works pretty well. Plans tend not to deviate from those too much. They may also set some exceptions for specific specialties where there might be a little bit more risk, or they want to do a little bit more diligence. Those are also available or configurable in our system. Um, I think we can probably take one more. I know we're pretty early in terms of time, but yeah, we can take a couple other questions. I'm just reading through here. Um, there are a couple questions, I guess, about sourcing of new addresses or new locations, how do we make sure that's accurate? And how confident can you be in that? And so the same method to validate whether something is accurate is used to source information. So like I mentioned before, right, we can take a simple example, maybe with a provider website. Maybe we scan that and we find something like for Dr. Smith, there are 8 different locations that Dr. Smith practices at. In your directory, you only list, 4, right? We would report those additional locations as potential ads, but we don't um, generally, that doesn't go through an automated process, primarily because we're not sure if the plan is contracted with the provider to actually practice and see patients at those locations. So we kind of view those more as leads, and if those leads are validated, then you can get a significant increase in your overall um, total locations to help fill those network adequacy gaps. So the confidence is based on what source. It's the same kind of method or same kind of technology that sources those locations. There is a bit of an extra step in terms of validating those locations are valid for that particular health plan under that whatever that line of business may be.
There's one question, Sanjay, on how do you weed out the
Yeah,
bad data on some of the websites that have invalid information. I think you kind of spoke to this.
yeah.
R3 is sort of stands for like relevance, recency, reliability. Our algorithm knows, gets a sense of like what's a good data source, what's a bad data source, and weighs it appropriately. And that helps formulate the confidence score. But welcome to that.
Yeah, Neil, I think, I probably papered over that a bit, so my apologies to the audience, right? So the way that technology works, as Neil said, we use this method called recency, reliability, and relevance. And so we won't just take any source in, right? We'll weight those based on those factors. So, basically, we'll say like a provider website is probably a much better source of truth or better source than, say, like a news article, for example, right? Because that can be from anything about anything. And so we'll weight information from that particular source at a higher rate. If there's been a more recent change, just to get higher rating. And then reliability has more to do, I think, with how many other um, sources or how many other kind of reliable, it's probably not the best way to put it, how many other entities, right, are using this source of information, right? The higher that is, probably the more likely it is that source is better. So we use all those types of weightings, and based on our algorithm and our experience, we come up with sort of the best um, score or most accurate guess as to what is accurate and what is not. So hopefully that answers the that question.
There's one more I think that's important. So do we have a mechanism by which insurers and providers can interact with our AI results to add comments or confirm or reject specific results once the location's flagged? And so, yeah, source system is very configurable and actually learns from feedback. And I don't think we have any screenshots of that, but Sanjay, you're welcome to go into more detail on that.
Yeah, I can speak to that. So typically, the way our system works is we employ 2 methods. So one is when you have a lot of confidence, we like to integrate with the health plan backend system so that you can automate these updates. And then where we have less confidence or maybe there's more risk, we also have integrated workflow and where you can do kind of just what was described, right? So for a particular location, um, if you have a if you have a score, maybe it's inconclusive, we're not quite sure which way it is, if it's accurate or inaccurate, an operator can take a look at that. They can use our workflow to look at all the different sources that we looked at, why that score was there, and then they can do their own diligence, right? And say, maybe they want to call the provider, maybe they want to do some other research, whatever it might be, look at a contract. Once they kind of make that decision, they can enter it into our workflow, and then they can, kind of leave a comment as to why they made their decision. And our system will actually learn from that operator input over time, and it will actually improve our algorithm so that you get less and less of those kind of inconclusive results over time. So that's the way it works, again, in practice.
Another question, do we have referenceable clients who can attest to our effectiveness? Yeah, happy to connect you. We work, again, with 4 of the 10 largest health plans in the country, a number of regional plans as well. Overall, feedback has been amazing and that's been able to grow pretty quickly, especially there's been increasing alarms from regulation standpoint, but happy to connect if you reach out to us after the talk.
Yeah, happy to refer you to existing customers. And then I think there's one other question, just I'll kind of combine these. It's kind of across, can this be used for specialty or phone number or other data elements? So yeah, I'll answer that. So currently, right, we have experience and focus more on the kind of critical directory data elements. So all the ones that I mentioned. So um, you know, address, phone number, name, specialty, ANP flag, like all those critical ones. We use this system to kind of validate and provide recommendations on what's accurate and what's not. But we're not limited to that. So especially once we are working closely with the health plan and can leverage their internal data, we also do a lot with network affiliations. Do you have the right network affiliations and lines of business associated with a particular provider or provider group? We're also starting to source kind of consumer value added information, and we're kind of doing more and more of this as time goes on. The same method of going out and sourcing data using a lot of these advanced AI and LLM techniques can be applied to things like, can we make sure we had a plan talk about fax numbers being a big problem, right? And we can actually source fax numbers. We can source, I think there's a regulatory requirement coming out for provider digital contact information, which I think is a bit nebulous, but it's interpreted to be either what website can I go to find out more about this provider, or do they have an email address or other digital contact information. We can also source that data using this same method. So it's a relatively flexible capability, but our core is definitely in those directory elements, and then other ancillary provider data elements to score and check whether it's accurate or inaccurate, and then also sourcing value-added data elements that plans or other entities are interested in.
I mean, the hope there is one could do like social determinants of health data, like language or other things that'd be useful to maybe even address disparities in access to care. It's just like the fundamentals within there's so much work to do in the fundamentals, like address and phone number, that that eventually we'll get there with plans. It's just like there's so much work going on with other sort of key data elements that, but the potential is definitely there with the algorithms we use, more broadly.
Yeah, and I think we have one other question, and then I think we may wrap up after this. How recent are your data sources? So, um, past 12 months, past 3 months, et cetera. So, um, data source wise, we kind of do this on demand and refresh relatively frequently. So, for plans generally, we work with them and um, kind of advise or recommend about a monthly update or monthly refresh of all this data, kind of cleansing out your ghost network locations, et cetera. And that usually aligns to when providers typically send data updates. It's usually on a monthly, they send these rosters and usually on a monthly basis. Sometimes it's more frequent, sometimes it's less frequent, but that seems to be the general cadence. And then on our end, we refresh data generally on like almost a weekly basis. And it depends a little bit on the plan and kind of their subscription basis, but the only limitation to us on recency or how frequently we do this is it's mostly a cost thing, right? So we have these algorithms run, and we can if we want to update more frequently, we can, right? We would just run our servers longer and for more time. But we find anything more than weekly seems to be a little bit too, like, you're not really getting any appreciable change within a week's period. So typically we go at the most on a weekly basis, and the way our solution is architected is it's on a plan basis. So we don't have this kind of huge database out there with all this provider data that we go out and refresh frequently, although we're thinking about building that, because it might be more efficient. What we typically do is with a given plan, we'll take in all the providers they're contracted with, and we'll go out and get all the data for those particular providers, and then we'll refresh that on the frequency that they are looking to refresh their data at, which is typically monthly. But again, we can do more frequently. We're looking to get to kind of a weekly basis, just so that there's no latency or anything when we're updating our plan customers on this information when they need it. Um, I'm trying to see if there are other specific questions we haven't covered here. Well, it seems like there've been quite a few. All right, I think that about does it. I think we've answered all the core questions. So I think we'll go ahead and wrap up now. But thank you, audience, for your engagement. We've greatly appreciated your questions and engagement throughout the webinar. Again, if there are other potential questions, if we didn't get to your questions in this, we'll be happy to follow up with you. And again, I think our contact information is out there either through AHIP or you'll get an email afterwards. But feel free to reach out with any other questions. And again, we really appreciate the audience's time and engagement. Thank you.
To our speakers, thank you for that great presentation and for sharing your thoughts. Thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you again and enjoy the rest of your day.